it's any less academically or intellectually rigorous. I understand it's UCL that's supervising your research, isn't it, Lee? So it is still going to be academically robust. Right, so I'll open it up to questions. I see Karen has got, I don't think there was anything in the chat, so if you've got questions, just pop your hand up. And I think Karen Hull had her hand up.
Yes, Peter, that was up by mistake. So that should have been a clap at the end of the
right,
actual.
okay.
So that was this, yeah, so it's a clap. Well done, everyone. I think it was a fantastic presentation, lots of good work, and so enthused to see this now all coming to fruition.
Okay. Is there anybody got any questions for anyone? I've got a question perhaps for myself and also for Liz about how we engage primary care generally, not just in cancer care reviews, but cancer generally. I think one of the problems that we've had, certainly in my patch, actually is engaging with primary care more generally, because I don't want to sound like the typical moaning GP, but primary care is under pressure, and there's lots of competing demands on our time. So how does primary care ensure that cancer gets the attention that it needs, and particularly, as Liz so eloquently demonstrated, the number of people surviving with cancer? We talk in primary care about we have got a certain expertise in non-condition management, like ischemic heart disease, diabetes, COPD, etc. And one of the things we talk about is actually treating living with and beyond cancer as part of that chronic disease management. But got any observations on that, Liz?
Yeah, so I think we have an opportunity on a few fronts. I think PCN development, which is in various stages across the patch, gives an opportunity to encourage PCNs to have their own little cancer team, and actually that they have a developed relationship with secondary care, so that there is that communication that Emma was describing so well. I mean, we're very lucky. We've now got an integrated cancer care lead who is going to sort of fulfill that role. So Katie came to do a PCN visit with me the other week. I think it's to encourage that. I think it's to encourage primary care that it doesn't just sit with a GP, and often it doesn't sit well with the GP. Actually, it may be that the experience for a patient is better served by seeing a social prescriber. I think Lee and Marion said the issues they were describing doesn't need a GP. It needs somebody with empathy and compassion. I'm not saying GPs don't have that, but empathy and compassion, and the knowledge of actually how to support that patient, how to signpost them. It's that. I think we've got the early cancer diagnosis tests, which gives us, as I say, a way into practices. I also think patient champions in every PCN should be a must, because that's the way that you can rattle on the door of your PCN and say, your website hasn't got any information on, be aware of bowel cancer month or whatever. So there's lots of ways in. We just need the right people with the right vision to actually knock down some of those doors. Often what you find in PCN world or primary care world is once you get that snowballing effect, other people can see the benefits of it. And actually it can be really time efficient. If you want to look at it, not from a patient point of view, but from a primary care resource, this can be really time efficient because those unmet needs are being met. Patients aren't ping-ponging backwards and forwards because they don't know where to go or they don't know how to articulate their problems. And also you're taking a group of people with that shared experience. And actually then that support from one another can be so fantastic, obviously for them, but also of benefit for the GPs and the primary care setup.
Yeah, I think that's absolutely right. And also that shared experience of where to go seek help. I mean, as primary care expands, as people have alluded to, primary care is not just about GPs anymore, and GPs have to get over ourselves in that respect. But it can be confusing for patients about who is the best contact, and I think that's where that touches on what the points that Emma was making, is that we have a lot of work to do about improving communication between primary, secondary, and indeed tertiary care, because there's definitely huge gaps that patients very easily fall through if we're not careful. I'm not going to suggest that this is going to solve all of them, but it's a step in the right direction. Couple more questions, Zoe.
Such great presentations, thank you so much. I really enjoyed them, even though while I was sharing the slides. Sorry if I've missed this, but as I was coming into the project a bit later on, but in terms of encouraging uptake amongst patients, because it's a very different approach to what they're used to, how will that be undertaken? So I know Liz touched upon sort of patient champions, so just interested in how that will be sort of managed.
Does anyone want to pick that up? Or Ginny?
I can never find the mic, sorry, because you said, Zoe, that it's a different approach to what patients are used to, but I'd say the vast majority of these won't be used to anything because this will be their first experience.
Okay.
They'll be newly diagnosed with cancer. This has to be kind of set up as the norm. It's very much like PCSFU. It's setting expectations when they become a patient from the start, that this is how your outpatient care will be managed. So they shouldn't know any different.
Yeah, I mean, I think, you know, previous work we've done has shown that unfortunately cancer care reviews is the GP, nurse, or even somebody else in the practice just phoning up the patient, running through tick box questionnaires, right, job done, quaff point secured, end of story, which is complete and utter waste of time for everybody. Even though the idea of virtual group consultations is novel in this context, it's been proven in other areas. Our local, for example, our local long COVID service is very much based on virtual group consultations, and it works enormously well. I think one of the lessons that primary care generally has learned from the pandemic, even though the different modes of consultation were forced us by the exigencies of the pandemic, and that's a whole different conversation. We tried to preserve the benefits of some remote consultation, because, you know, patients particularly do like the opportunity, the use of electronic consultation, the use of telephones. We kind of abandoned single videos because they had no benefit. So, you know, it's horses for courses to a degree, and it's trying to find out and preserve the advantages of ways of consultation that perhaps were forced upon us, but do have certain advantages. You know, the fact even that we're still meeting on Teams, we now could work face to face if we wanted to. We had this conversation amongst ourselves, but you know, we know that we're going to get a much better attendance if people can just dial into a meeting from home because of its obvious advantages, and it's just extending that into a clinical setting. Right, I got Lisa and Tina and Lisa and Liz, but I also had a question from Alice Parr in the chat, which I think is a very good one, and I'm perhaps going to direct it to Lee. Is, are we going to design a set of criteria that can be used as suggested competencies to take forwards? If I've understood Alice's question properly, are we trying to set up a set of standards about what actually is a good virtual group consultation? So either Lee or Lisa perhaps might pick that up.
Yeah, I think actually it'd probably be useful for both of us to jump onto that one. So absolutely. Part of the evaluation is going to be looking at the initial training as well, to evaluate what the staff feel about that and how well it actually sets them up to do those initial group CCRs. And then obviously, as I mentioned, the evaluation is what we call grounded theory. So we will start to feed back from those initial themes that we are identifying. Obviously, each experience will be individual, but we will start to pick out some core central themes that all patients are reporting, and then we can actually start to devise some competencies for what the actual review should look like, and start to think about how we can shape those for potential other types of reviews, as I say, for people maybe at end of life or for teenagers, so we can continue that evaluation process. Was there anything you wanted to add on that, Lisa?
Yeah, just really to build in that the supplier for the training is very experienced. They already provide this sort of training for health education in England, etc., and with in secondary care, etc. But we will be building this competency into as we evolve through. But also some of the, going back to Zoe's question, some of the uptake is down to how the message is managed for the patient. So there's two elements to that. Some of the training will incorporate offers training and support for facilitators such as reception staff, those people they may be offering the session in the first place. But also the toolkit itself has been co-designed with patients, which includes information leaflets and a letter, all those things that we've pulled together to try and improve uptake.
Okay, thanks, Lisa. Alice, if that answers your question, like your question in the chat. If it doesn't, put something else in. Lisa, you had a question of your own?
No, that was just I just wanted to say.
Right. Okay, Liz.
Yeah, I was only just going to say, I think we need to remind ourselves now that cancer is not a sort of secondary care speciality. Cancer is all of our business, and actually the majority of time a cancer patient spends is in the community, in their own home, and that we have as much to offer to a cancer patient as secondary care does. And I think it's just an important thing to message to get across.
Yeah, no, I'd agree, and I think it's one of the most unfortunate consequences from a medical point of view of the pandemic is that I think primary and secondary care relations have suffered as a result to the detriment of all parties, particularly patients. So improving those relationships, as I say, every bit of effective clinical transformation we've ever done has involved primary and secondary care working together. And in this case, working together with patients. And on that optimistic note, if no one has got any other questions, I'll draw this webinar to a close. For those people that are either late coming, the recording will be posted on the Alliance website, and we'll be sending out the slides to everybody who's attended. And I'm sure the authors and contributors of the slides are happy for them to be used. There seems to be particularly interest in Fiona's mind map of the cancer patient experience, which is, I think we're all agreed, is extremely powerful. So thank you very much for your time. We are going to be repeating this webinar tomorrow week at lunchtime. We'll be delighted to see you again. Otherwise, thanks very much for your interest and your time. Thank you very much to our speakers, and Zoe for driving the slides, and Lisa for being Lisa, and without whom this project would never have got off the ground.